Hi there, this is part 2 of the analogy looking at internuclear ophthalmoplegia. In part 1 we looked at horizontal conjugate gaze and how the degree of damage to the medial longitudinal fasciculus can cause either an internuclear ophthalmoparesis or ophthalmoplegia. This video will look at other disorders of horizontal gaze, namely lateral pontine lesions and INO-related variants including Robino, 1.5 syndrome, half-and-half syndrome and the posterior INO oblutes. This will be a continuation of part 1, and so if this is the first time you are seeing the analogy illustrated, it will be worthwhile to watch part 1 beforehand. At the end of part 1, we looked at Bino, which is normally due to a midline MLF lesion between the lower midbrain and pons. Although uncommon, if a midline lesion occurs in the upper midbrain, it can damage both MLFs and both medial rectus subnuclei. This leads to the eyes being slightly abducted in primary gaze. This is because resting eye position in primary gaze relies on all the extraocular muscles equally contributing to keep the eye centered. However, if the medial rectus muscles cannot contract because the muscle or its nucleus is damaged, the eyes will naturally deviate outwards due to the unopposed pull action of the lateral rectus muscles. This is represented by the red rectangles illustrating the medial rectus subnuclei disappearing to cause the eyes to move laterally. In this position, the eyes are positioned as if they are looking at the sides of a wall around them, giving the non-politically correct but descriptive term of wall-eyed bilateral INO, or Robino for short. Similar to Bino, in Robino on lateral gaze, there is loss of adduction with dissociating abduction nystagmus. As the medial rectus subnuclei are also damaged in Robino, the eyes are kept in an exotropic position. As the upper midbrain is damaged in Robino, the convergence pathway alongside the medial rectus subnuclei are damaged, meaning the eyes cannot converge. In a Bino lesion, however, convergence is intact. Hence, the difference between Bino and Robino is where the midline lesion is. If the upper midbrain is spared, it will cause a Bino lesion. If the upper midbrain is involved, a Robino will occur. Moving away from the midbrain, if a pontine lesion damages the right PPRF, as shown by the white-blue handle disappearing, then on attempting to look right, the eyes will not move as the command to do this from the right PPRF has gone. Looking left is normal. Of note, if a lesion occurs acutely, such as a stroke, a right PPRF lesion can present as fixed conjugate gaze deviation to the left. This can be best fought off with the left and right PPRF constantly pulling against each other in a tug-of-war action, and in the process the eyes remain in the center. But if suddenly the right PPRF is damaged, the left PPRF is unopposed in pulling the eyes to the left, and so for a while, they are fixed in this gaze. In this case, if you ask the patient to look straight, they will not be able to. Over time, through compensatory mechanisms, the left PPRF fires less, and so the eyes move back to the center so that they look straight ahead, but without the ability to look right, leading to the right horizontal gaze palsy. If the left PPRF is damaged, the mirror image occurs to the previous case. Looking right is normal, but on attempting to look left, as the left blue handle is gone, there is nothing to pull the eyes to the left, and so the eyes stay in primary gaze. If the right abducens nucleus is damaged, as shown by both green rectangles disappearing, the eye movements would be the same as in a right PPRF lesion only, with right horizontal gaze palsy but normal left horizontal gaze. This is because the abducens nucleus links the PPRF to the rest of the horizontal gaze pathway components. And so, if the abducens nucleus is lost, it is as if the PPRF is also lost as it cannot influence eye movements, which is illustrated in the analogy with the right blue handle disappearing as it is not attached to anything. If the left abducens nucleus is damaged, the exact mirror image would occur with normal right gaze and left horizontal gaze palsy. If you have right PPRF damage causing a right horizontal gaze palsy, but then also damage the right MLF to cause a right INO, you get what is known as right 1.5 syndrome. The 1 stands for the fact that when attempting to look right, there is a full right horizontal gaze palsy. The half stands for the fact when looking left, there is half of a left horizontal gaze palsy, as the left eye can abduct fine, but the right eye cannot abduct. Looking at the analogy, it is difficult to imagine how a single lesion could damage the PPRF and the MLF going to that side. In reality, when the MLFs cross over, they come close to the abducens nucleus, and so a single lesion affecting the right abducens nucleus can also damage the right MLF. It may be noticed that the left eye slightly deviates outwards in primary gaze. This occurs as the right PPRF is damaged, allowing for the unopposed drive from the left PPRF to pull the eyes to the left. However, as there is also right MLF damage, the left PPRF can only pull on the left eye and not the right. This leads to the left eye being kept in an exotropic position opposite to the side of the lesion. This is known as paralytic pontine exotropia. If you have a left 1.5 syndrome, the mirror image of the previous case will be seen. Looking right, there is a left iono with loss of left eye adduction with right eye abduction nystagmus. On attempting to look left, there is a left horizontal gaze palsy as the left PPRF has gone. The right eye is held in an exotropic position. If the right abducens nucleus and right MLF are damaged, as shown by both the green rectangles and MLF disappearing, the right blue PPRF handle is disconnected and so cannot pull the eyes to the right, causing a right horizontal gaze palsy. Looking to the left, there is a right iono. The left eye is exotropic. If you have a left 1.5 syndrome with abducens nerve damage, the mirror image will be seen where looking to the right, there is a left iono. On attempting to look left, there is a left horizontal gaze palsy. The right eye is held in an exotropic position. Interestingly, a lesion damaging the ipsilateral abducens nucleus and contralateral MLF to cause a 1.5 syndrome can also damage the ipsilateral facial nerve. This is because the facial nerve has an unusual course where it wraps around the abducens nucleus. If this happens on the left side, you will have a left 1.5 syndrome plus an additional low motor neuron facial nerve palsy. This would be called a left 8.5 syndrome due to there being a left 7 cranial nerve palsy plus a left 1.5 syndrome. If a lesion damages the right MLF and right abducens nerve, as shown by the thick grey rope going to the right eye and right green rope disappearing, this is called a right half and half syndrome. The first half stands for the fact when looking right, there is half of a right horizontal gaze palsy, as the left eye can adduct normally, but due to the right abducens nerve damage, the right eye cannot abduct. The second half stands for when looking left, there is half of a left horizontal gaze palsy, as the left eye can abduct normally, but due to the right MLF damage, the right eye cannot adduct. The typical abduction nystagmus of iono is seen. With the left half and half syndrome, the mirror image of the previous case occurs where on looking right, the left eye cannot adduct, and on looking left, the left eye cannot abduct. Looking at the analogy, it might be difficult to appreciate how a single lesion can damage the ipsilateral abducens nerve and the MLF going towards it. In reality, the abducens nucleus is anatomically close to the MLF coming towards it, and so an MLF lesion can also damage the abducens nerve. Rarely, a lesion can damage the connecting interneuron between the right PPRF and the right abducens nucleus motor neurons without damaging either structure. This is shown in the analogy by the right blue handle disconnecting from the right green rectangle, but all the components are still present. If the patient looks right, the left eye can adduct, but the right eye cannot abduct, as the right PPRF cannot tell the right lateral rectus to fire. There is also a dissociated adducting nystagmus of the left eye due to the right PPRF overfiring in an unsuccessful attempt to abduct the right eye. Looking left is normal. With a left posterior iono of Lutz, the mirror image of the previous case occurs. On looking right, the eyes move normally, but on looking left, there is a dissociating right eye adducting nystagmus with left eye abduction paresis. The eye movements are the opposite of a normal iono, as instead of loss of adduction with abducting nystagmus, there is loss of abduction with adducting nystagmus. Hence, the terms reverse iono or the iono of abduction are often used. Technically, this is not an iono as there is no MLF damage, but rather these terms help you to remember that the eye movements are the opposite of a typical iono. The presence of the adducting nystagmus helps differentiate the posterior iono of Lutz from an abducens nerve palsy, which does not have nystagmus. Uncommonly, if a posterior iono of Lutz lesion does not have nystagmus, you can test the patient's vestibulo-ocular reflex. If you turn this patient's head to the right while asking them to look at your nose, both eyes should reflexively move to the left, where previously the left eye that could not abduct can now abduct. If with a vestibulo-ocular reflex the left eye still cannot abduct, this supports the left abducens nerve palsy. Building on from the first video, this video has focused on iono-related syndromes due to various brainstem lesions. When trying to localize the lesion of someone with abnormal horizontal eye movements, having a few guidelines to follow is helpful. The first thing would be to ask yourself if one or both eyes has a problem. If both eyes are unable to look in one direction, there is likely a problem with the PPRF or abducens nucleus ipsilateral to the direction of the gaze palsy. If one eye is unable to look in a particular direction, ask yourself what it cannot do. If the eye cannot abduct, there is likely a problem of the ipsilateral abducens nerve. If the eye cannot adduct or adduct slowly, consider MLF damage. Whenever dissociated horizontal nystagmus is seen, this tells you that the PPRF in the direction of the nystagmus is working fine.